Today's session that we are here, this breakout session, is the biology of addiction. This breakout session is being presented by David Boblitt, the substance use disorder professional with Sundown and Branch. David has 20 years experience in the addiction field and has worked for Sundown and Branch in the youth facility since 2003. He has a passion for the science of addiction and strives to educate people on the disease. Another thing I'd like to mention is to thank David for his service as a U.S. Army veteran and thank him for being here today. And I will hand it over. This session goes until 2:30, and towards the end we'll have the opportunity for Q&A. All right.
Hi. Here's the thumbs up. All right. So anyway, my name is David Boblitt. I work at Sundown and Ranch. And before I start, if I make any jokes or anything, I'm not making fun of addiction. I'm not trying to take it light. I work with youth, and if you don't get their attention, they'll eat you alive. So this is kind of the way I present. Okay, so I've been employed at Sundown. I was a patient at Sundown and Ranch in 2000. I went to treatment after an intervention by a SWAT team, and it's strongly suggested by this guy in a black robe that I go to treatment. So I did, and I ended up accidentally getting sober, and I started. It's weird at Sundown, like I think they extended me for 20 years. It's not like I probably haven't even graduated. They just kind of keep you there. Later, Dr. Montgomery, like our old medical director, we'd be in a meeting and he'd go, well, this person's really sick. You need to keep them in Yakima, hire them. So now I know what happened. So I am in long-term recovery, 25 years in a row, nights and weekends included. Kids are always like, you don't even smoke pot, bruh? I'm like, no. And I do work in the youth facility. I work with the Bellevue Crips and the Redmond Bloods. Driving mom and daddy's Beamer, you know. But I do have one patient that doesn't sag their pants and pulls them up. I'm very proud of that. So I was in the Army from 1983 to 1989, 11 Bravo, 11 Hotel Echo Niner. And I left the Army in 1989 because they started doing urinalysis tests, and I did not want to stop smoking pot. So, and I actually got a DUI at Fort Lewis when I was, I pulled up and drove up on the lawn at the entrance of Fort Lewis. And unfortunately, I wasn't on post, so the UCMJ couldn't really do anything, so I had an it was really a mess. So my time in the Army and my active addiction, like I say, I'm in long-term recovery, so I do understand this disease. So next slide, please. So first of all, for anybody who serves, thank you for your service. It's one of the most wonderful things you can do for our nation, and I'm very proud of mine, even though I was drunk a lot. Next. Now, when I was doing this presentation, my dog, I was on my laptop, and he kept jumping up in my lap, so he wanted to be in it. That is Zelly, my mini Australian Shepherd, who keeps our whole family safe. So Zelly says hi. All right, next. So today, I'm not going to give you my opinion. I'm going to use citable resources, and those resources are going to be the Diagnostic Statistician's Manual, Edition 5, which contains every brain disorder, mental health disorder. The credential that I hold allows me to diagnose substance use disorder out of this book. The Journal of the American Medical Association, some of the information I got on dopamine come out of there. Dr. Timothy Huckabee, who is actually on the committee that wrote the definition of addiction and the Diagnostic Statistician's Manual, Edition 5. And of course, I'm going to present it. All right, let's see. This is what we get a lot. Go ahead. Yes. Only one glass of wine a night. Now, what I know is that if you drink your wine out of a box, they're made to get robbed. Just putting that out there. All right, go ahead. So the CenterOnAddiction.org tells us that addiction is interesting because it affects so many areas of our life. And obviously there are some diagnostic criteria that we look for: a loss of control, compulsion to use, withdrawal, which is called abstinence syndrome. We look for the effects to family and life and all of that stuff. So a lot of times people miss it because it affects so many areas. They view it as either a mental health problem, an ethical problem, a spiritual problem, when really it's kind of all of those. And so that being said, go ahead, please. So it affects us biologically, psychologically, and sociologically. Biologically, it affects us in the ways that I'm going to explain to you today, with neuroadaptation, enzyme induction, other physical changes to the body. It affects us psychologically because when I was 13 years old and I started smoking weed every day, I had to learn how to take money out of my mom's purse, which I'm not a sociopath. I have a conscience. I knew that I was doing wrong and I was choosing to do that. And it affected me because I'm acting out of accordance with my morals and my values. I'm watching everybody graduate when I dropped out of school at the age of 13 because it really got in the way of smoking weed, you know? And so I'm watching all of this and it affects me psychologically. And it definitely affected me sociologically because by the time I was 15, I didn't even know anybody that didn't get high. You know, I went to a private school, I played soccer and I dropped soccer, I dropped all of that. My whole social structure changed. So, of course, my mom, well, he's just hanging out with the wrong people. Well, I'm selling drugs to those people, Mom. I'm the wrong crowd here. You know, he's just depressed. Well, yes, I am. And I'm also addicted biologically. And by the way, I come by it honestly. Every male in my family is an addict or an alcoholic. Okay, next please. Oh, there we go. So addiction lives in an area of the brain called the mesolimbic system. So on top of our brainstem, we have this little bundle called the nucleus accumbens, and it's covered the rest of the brain called the neocortex. But this part right here, this has been around for tens of thousands of years. This is the animal brain, the primal brain. No thought happens here. Hunger, sex drive, all of that stuff happens here. Fear, anxiety, all of that, looking for threats. This is the mesolimbic system, and this is where the survival center of the brain is. When you eat food that you like, the reward pathway that I'm going to talk about here is going to release some chemicals and tell you, hey, this is good, you need to keep doing this, you need to keep doing this. Well, a lot of receptor sites are along the way. I just wanted to put that in there because cocaine, heroin, and nicotine all affect what we call the mu receptor sites. Matter of fact, E.M. Jelnick says that nicotine is the most addictive substance known to mankind. And so, yeah, those are the same receptor sites. Like, you know, well, at least I'm not using heroin. Okay, well, good luck with that. All right, we made advance, thank you. So let's talk about the reward pathway. So this is an area of the brain that reinforces behaviors, like positive type behaviors. So, like eating food, you know, or the thing about the reward pathway is when we do something that is good for us, it releases dopamine. Go ahead and eat it one more time. All right, and not again yet. Okay, so examples of rewarding behavior: eating food. I mean, obviously, sex, being nurtured, seeing someone you love that you haven't seen in a long time. All of these things will release dopamine, and they give us a feeling of well-being. So dopamine is the woohoo neurotransmitter. One click, please. Woohoo. Woohoo. Okay, next slide, please. I know, I found that GIF, and I was like, okay, I gotta use this somewhere. Okay, so this is out of the Journal of the American Medical Association. And it says that dopamine is most famous for its pleasurable effects. It can make us confident, euphoric, sometimes aggressive, hyperactive, but not all of those at once. Like if you're using an opioid, obviously you're going to get euphoria. So those of us with substance use disorder, or so those of us that are addicts, we produce dopamine in levels that it's really hard to explain. The first time that I ever smoked marijuana, I already knew. I'm like, well, this is my job for the rest of my life. Cancel everything. I'm a professional stoner, bro. That was it. I knew it because of how my brain felt. All right. And I'll show you what dopamine looks like. I have a picture of it here. Go ahead and click once, please. There you go. Right there. Okay. This game. Okay. Anybody in the Army will get this. The safety brief. Okay. Trust me, in Germany we had safety briefs on we had a safety brief on how to go to the safety brief. Anyway, go ahead. So the mechanism of our disease, as described in the Diagnostic Statistician's Manual, edition 5, is neuroadaptation. Neuroadaptation is described as how the brain attempts, the mechanism which attempts to adapt to high levels of unnaturally produced dopamine. Remember, I told you, when we eat food, when we do this stuff, we release dopamine. But when we do substances, especially like alcohol, marijuana, but the opioids, what we call the water solubles, opioid, methamphetamines, amphetamines, they release dopamines in a level that is just unreal. So remember, neuroadaptation is the mechanism by which the brain attempts to adapt to high levels of unnaturally produced dopamine. One more, please. So, wait a minute. I forgot to put the other one in there. Okay, so let me explain neuroadaptation first, because I think I forgot a slide. So essentially what happens is in our brain, we have these neurotransmitters in the nucleus accumbens. Okay? So when I do something like eat food, one of these neurotransmitters releases dopamine, and it goes all the way across, and it bonds with that receptor site. Now, the first time that I ever smoked weed, or when I did methamphetamine, like it would release all of that dopamine at once, and it would just rush across the synaptic cleft and be like, oh my God, this is so good, this is so awesome. And the first time I did cocaine, I was sitting there with a guy I didn't even know making plans for the next 5 years. I was like, blah, blah, blah. It was just an amazing feeling. And what had happened is I released so much dopamine that I had this feeling of well-being that is completely unreal. The problem with this is we have another mechanism in our brain known as neuroplasticity. And neuroplasticity is the brain going, oh, no, that's way too much dopamine. And so what it does is it starts to down-regulate dopamine. So now I do that same hit and it feels good, but it doesn't feel as good. Now what do you got to do? More. Exactly. Kids ask me all the time, hey Dave, what was your drug of choice? I'm like, more. Preferably what you had in your pocket so I don't got to waste mine, you know? Big drug of choice. I'm an equal opportunity addict, okay? You know? So if I were to, so now I did an intake this morning, and I had this young man sitting in front of me. And he got the high score, 11 out of 11 symptoms. I'm like, yeah, you got the high score, bro, you know? So, and then what happens is whenever they do that, I say, so I'm going to place a diagnosis of substance use disorder in your, I'm going to diagnose you with that. And I always ask him, why don't you ask me what that means? And then I would open the DSM-5 and I would do the following. This is the definition. Drugs and alcohol activate the pleasure-producing chemistry of the brain. Hit it again, please. Overstimulation of the pleasure pathways causes them to neuroadapt, interfering with the normal experience of pleasure. One more time, please. Addiction is a disease of the pleasure-producing chemistry of the brain. Neuroadaptation is the mechanism, the reason for the disease. Go ahead. Once neuroadaptation occurs, cessation of the drug use leads to an inversion of the high, and sobriety becomes pleasureless. Bang. I know, right? That one got me when I read that for the first time. So it leads to an inversion of the high, and sobriety becomes pleasureless. You see, what we're talking about here is not an ethical weakness. It is not a moral weakness. It is not a choice. It is brain chemistry. People say all the time, addiction's not a disease because it starts with a choice. And I'm like, well, so does herpes. You know, it starts with a choice. Just saying, you know. Okay, sorry. I'm just like, I get frustrated. I'm like, you know, okay, it starts with a choice. All right, go ahead. So let's talk about addiction. So one of the things is like when I do this lecture in the adult facility, I'm like, I would hate to think that my beloved Sundown Ranch would ever misdiagnose any of you. So let's go over these symptoms. Compulsion, a loss of control. The addict is compelled to use. Many times we become frustrated as providers. I mean, I get this, but because we're like, wait a minute, dude, you know you had a UA. Why is it positive? You knew you had this UA. Why is it positive? They're like, I don't know, man. You know, instead of thinking, the addict mind works different. See, the addict doesn't think, well, maybe I just shouldn't use. They think, well, I've got a UA next Wednesday, so I'll just get the cat to pee in a cup and bring it with me. Addicts are the only people I know that think it's normal to carry around someone else's urine. So, but you see, the thought never, and I'm an addict, so I can say that, okay? So the thing is that the thought of not using is not an option because the addict is compelled to use. Go ahead. Continued use despite adverse consequences.
Amen.
I had 3 DUIs, I had all kinds of problems, and every single time, I went to treatment a few times, and every single time the thing that I would not give up was smoking marijuana. You get what I'm using? Like, I mean, you get what I'm saying? I would not stop using marijuana because I didn't agree with it. But the problem is, I knew that it was causing problems. The problem is, an addict is a person who uses, even though they know it's causing problems, the addict can't not use. That's the thing, is, you know, you can confront an addict with all of these consequences, like, well, look what you're doing to your family. Okay, that's part of the treatment process. But you see, the problem is the part of our brain that regulates survival has been hijacked, and it has been, a whole new operating system has been written to where I need drugs more than I need air. I need drugs more than I need my family. I abandoned my daughter. I was 13. She was 13 when I went to prison. 13 years old. But you see, that wasn't enough to get me sober. That was not enough to get me sober. And I'll tell you that I love the biology of addiction, because when I learned that, I realized I'm not a sociopath. I'm not a psychopath. I am an empathetic, loving, caring individual, the people that I respect in the world. Because of the biology of addiction, my brain was wired different. I'm wired different. That's okay, I know that now. All right, go ahead. Craving, a daily symptom of the disease. Go ahead and click it one more time. So it's a psychological obsession with getting, finding, and using the drug. It is absolutely obsessed with continuing to use. Craving is it's just like anybody, you know, I'm sure some people have tried to quit nicotine, and it's really hard to do. Like, you think about it a lot. You eat, and you're like, oh my God, you think about it, you know. You see it on TV, you're like, oh my God. And it's the same thing with drugs. In early recovery, we continue to have these cravings. Now, I love what we do at Sundown Ranch. We do something called urge surfing, so we're able to kind of really deal with these cravings. We've actually learned that the worst thing you can do to an addict is shame them. Like 10 years ago, a patient would say, I'm having cravings, and I'd be like, think about how that would hurt your family. So I'm going to shame him for something that's natural. Boy, that was great. Nowadays, we normalize it for him. This craving is normal. So essentially, what urge surfing is, and I'm just kind of going a little off right now, but I'm kind of excited about it. So urge surfing is that we acknowledge that cravings are normal. And then what I have them do is they sit there and they have their hands straight and their knees straight, and I ask them to come back to their body. It's called ACE. So, okay, where do you feel it? What's happening with your legs right now? You know, his foot's tapping, you know, and so he identifies all of these body sensations. We talk about that for a few, and then I ask him to do what's called square breathing. You know, like count to 4 and then picture the square, and it's called mindfulness. And then I ask him to identify 3 things in my office. And by the time we're done, the craving is past. You get what I'm saying? So we need to, and this is because this is part of the biology of addiction. Cravings are biological. Go ahead, please. And this is what we call a distortion of perception caused by craving. I love this part. Go ahead and click, please. Under intense craving, the user is temporarily, oh, no, back one, please. Under the pressure of intense cravings, the user is temporarily blinded to the risks and consequences of using. And I'll tell you that I quit using so many times, I'm like, I'm so done. I am so done. I'm really going to quit this time. And I'm not lying to you. I really believe this. I really believe this. You see, compulsion is not rational, and it is not planned. And yet, every time, I always come back to relapsing because I was blinded to the risks and consequences of using. I've had patients leave treatment. I'm like, bro, you're on felony probation. You're going to go straight to jail. And they're like, it's Friday, bro. You know, I'm not kidding. And then, like, literally, I'm going to get 2 days of getting loaded, and I'll deal with that on Monday. And it makes sense to the addict because of the brain chemistry, because of neuroadaptation, because of the need for dopamine. Go ahead, please. My son-in-law actually has this shirt. I know, I was like, okay, once again, I'm not making fun of alcoholism. I just thought it was go ahead, please. I know, I debated putting that in there. So, Dr. Timothy Huckabee, who actually helped write the definition of addiction, and I'm burning through these slides. Okay, so he helped write the definition of addiction in the DSM-5. And I print this out and I give, this is a 2-page reader, and I give this to all the families because I want them to see this. That the part of the brain that regulates survival, that keeps the heart beating, the lungs pumping, and all of that, the survival center, the nucleus accumbens, has been hijacked. It has been rewritten. Neuroadaptation has told the addict that the only survival they need comes from continued release of dopamine from substances. You see, it's cheating. You know, I mean, yeah, I just ate that salad, was great, some dopamine, you know, a little bit, but you see, as an addict, I need more. I need instant euphoria, instant euphoria, instant euphoria. The problem is, that part of the brain has been hijacked. Go ahead, one more slide. And so he goes on to say, at this point, addiction has become a disease because it has changed the physical structure and the function of the brain. It has changed the physical structure with neuroadaptation and the function of the brain. Ergo, it is a disease. Now, you know the American Medical Association has been calling alcoholism a disease since 1954 because it has all of the earmarks of a disease. But that's really not convenient for a lot of people. It's just not convenient. It's stigma. Oh, I don't have a disease. You know, well, you know, you do. And it's really, well, I'm not saying you do. I'm just saying when I'm talking to a patient. So the problem with that is a person that understands and views it as a disease actually has to stop. It doesn't work for the person that wants to get Cali sober. Does anybody here know what Cali sober means? Cali sober is when I'm going to quit everything but the weed, bruh. We call that Cali sober. Like, you know these guys because they're always, hey Dave, I've been sober off meth for 3 months now. Sober off meth. To me, and I'm not dissing on that, by the way, I'm open-minded, whatever improves somebody's quality of life. But for me, what I know about neuroadaptation is if I have a beer on the way home from work tonight, I'll be back in prison in a week. That's who I am. That's how I am. But hey, that's just for me. But that's because my brain is different. Now, that being said, I don't want to give people totally bad news. I mean, here's the thing. Neuroadaptation occurs, readaptation occurs as well. Matter of fact, an adolescent can reverse neuroadaptation and recreate normal dopamine production within 90 days. That's why at my beloved Sundown Ranch, actually Danielle Fleming and myself, we started what was called the morning exercise program. So now the patients have to get up in the morning and they go to the gym and they have to be active. 7:30 in the morning, these boys are like, what? So they got to go over there and shoot hoops. It's brilliant to watch. I wish I could videotape it. I'd make millions on YouTube. But the reason we do that is because obviously exercise produces endorphins and it stimulates the normal production of dopamine. And then neuroplasticity says, okay, wait a minute. Okay, now we have to re-regulate and up-regulate the production of dopamine. And then we start to feel normal. It took me about 2 years, my first 2 years of recovery. And it's not like I felt horrible and dysphoric and, oh my God, the sky is falling for 2 years. You know, I enjoyed some things. But now in my life, I can wake up and get excited about a video game. Like, you know, all that stuff that used to bring me joy. And to be honest with you, I don't even crave anymore. I've been sober 25 years. It's just not even a thought. So the brain does heal. This disease does go in remission. It does. But the best way that we have found for that to happen is for total abstinence. And please don't hear me say that I don't believe and I'm not open-minded. I'm completely open-minded to harm reduction. I know, in my field, that's dangerous. All right, next slide, please. So another physical change that happens in our bodies is called enzyme induction. So the first time I ever got drunk, and I'm going to apologize in advance for this, I stole a bottle of Canadian Mist from my father. The reason I stole it is because he wouldn't miss it. It was a gift. And I went across the street with this other kid, and we went into the woods back behind the house, and we drank. And about 35 minutes later, he was totally unconscious. And I'm like, bruh. And he wouldn't get up. I was terrified. I thought he was dead. So I had to go get my dad and, obviously tell him myself. Now, over the years, I never really thought, now this is the first time either one of us ever drank alcohol. Why did he pass out and I did not? Well, the answer is enzyme induction. You see, I have a genetic predisposition for the disease of substance use disorder. And so therefore, when I drank alcohol, my liver already knew what it was. It was very familiar, and it had no problem creating what we call alcohol dehydrogenase to metabolize the alcohol. See, he didn't have that, so he was unconscious. See, I had tolerance before I even drank. Now, when I'm doing an intake at the youth facility, when we talk about alcohol, I'm like, well, how much you go through, when you drink, how much you go through? What do you guys think the average is?
12-pack?
Around that, 12 to 18 beers. Yes, which is normal. See, for me, I'm like, well, yeah, I bring a 12-pack to a party, so I didn't have to bum all my beers, Like a 12-pack just gets me started. That's the kind of tolerance we have, and that's why tolerance is one of the diagnostic criteria. Because the amount that this young man that I did today, the amount he drinks would be a coma for a person without this disease. You see, without enzyme induction, you'd be in a coma drinking that much. My wife, she's like a total normie, I've never even seen her finish a beer. If she had 3, she'd probably be unconscious. You see, that's the difference, is our bodies are different. We have physiological differences. Now, not everybody has enzyme induction. The people that are genetically predisposed, which is about 60%, have what we call enzyme induction. Once again, this is a physiological change that changes the functioning of the body. All right, one more. All right, so let's talk about risk factors. So oftentimes we have people in our life that we worry about, and we're like, is that person an addict or an alcoholic? Usually a person doesn't have to ask that if there isn't a problem. If you think it's a problem, it probably is. But there are certain things that put us at a much higher risk for alcoholism and addiction. So can we go just once, please? So, oh gosh, I guess I didn't do those one at a time. All right, well, so family history of addiction now, 60%, this takes up 60% of the risk factors. Like, if I have a family that has a biological addiction, I have a 60%, that's part of the risk factor. So, I knew, luckily my son totally rebelled. He went to college, got good grades, never did drugs, nothing like me. Totally rebelled. So I was worried though, because I thought he was a sitting duck for this disease, but luckily he was not. So that is a huge one. Family problems, a lack of emotional safety or stability can also cause a problem. Oftentimes, if an adolescent lives in a chaotic environment, trauma can be a huge risk factor for addiction. So obviously, the family environment, the ability to talk healthy about problems and feelings and emotion and to process those. So another risk factor are mental health problems. We talked about this a lot today, is that if a person has a mental health problem and is misdiagnosed, oftentimes what we do is we self-medicate. I cannot count the times that a kid has told me it's the only thing that helps my ADD. Like, if he only knew, that's like making it worse. But that being said, he's treating the symptoms. He's medicating the symptoms. Because if he doesn't know he has a mental problem, if he doesn't know he has severe depression, if he doesn't know he has generalized anxiety, the chemicals are going to make him feel normal. Or her, I'm sorry, I work with boys, so I always say him. So that being said, mental health problems is self-medicating. It causes a huge problem. And by the way, my group hates it when I say this. Statistically speaking, they make fun of me. They did it yesterday. They're like, oh, don't tell me, Dave, statistically speaking. But statistically speaking, a very large percentage of people with substance use disorder have a co-occurring disorder as well. Very seldom do we see someone who is just an addict or an alcoholic. Oftentimes depression, anxiety, severe ADHD, all of that stuff could be misdiagnosed. Bipolar too, by the way. Exposure to trauma. This takes up the other 30%, and which is incredibly important with veterans to understand that there is significant trauma. The problem is people define trauma differently. Let me tell you how I define trauma. Any kind of psychological scarring. Trauma can be abandoned, not having your parents there. It's not just abuse, you know. It's seeing things that you shouldn't see. Witnessing violence, being the victim of violence. Trauma can be whatever it is. I went through trauma therapy in early recovery, and it was because of my shame and guilt, my self-loathing in early recovery. So I went and saw a therapist, and we talked about my trauma, and that was my trauma, was, abandoning my child and how I felt about myself. So anything can be trauma, but this trauma causes us to continue to use, because as long as I'm producing dopamine, I'm not thinking about the pain, Trust me when I tell you, methamphetamine, instant happy. The only problem is, there's not enough of it in the world to cover my pain, And 37 projects stalled due to lack of floor space was another problem. So, anyway, environmental factors, social media, and other media making it look fun. My friend Marley, Dr. Provac, she did this presentation we presented at a Catholic high school, and she did hers on social media addiction. And by the way, dopamine has been linked to all of these addictions. Gambling, exactly the same thing, by the way. Sex addiction, exactly the same thing. And she talked about social media addiction. She talked about how those likes get a hit of dopamine. The problem is we live in a society where media just absolutely glorifies this, You just watch a rap video, man. It's Glocks and weed and all of that stuff. And all of the kids that I work with, they glorify this. And social media is making it a lot easier to access this, learn about this. I'm not saying social media is evil, and I'm not blaming on it, but it has been added as an environmental factor. When you look at the research, it is an environmental factor. Now one of the biggest, is the age of first use. So when I do marijuana education, I quote a study by Philip Dennis and Winters and Lee from 2002 and 2008. And Philip Dennis came to the conclusion that regular use of marijuana 3 times or more a week before the age of 15 will have a 63% chance of adult dependence. Winters and Lee continued this study in 2008, and they found that the younger you start, the higher the percentage. I started at 13 years old. I had an 85% chance of addiction. I took those odds. I did. All right, next. Wow, I might be going too fast now.
You might have wonderful, lots of questions.
I hope I do. I love this. I'd much rather have a discussion. All right, so what I put on here is I put a link, and I love this right here. Drugfree.org is a great place for information, but this link will lead you to a screening tool. And this is for people that have adolescents. This one is designed for children. They do have them for adults as well. This is the one that I'm familiar with, though. And essentially, it's a check mark. Obviously, it's a web page, so I couldn't actually put it in here. But when you get there, it asks a lot of environmental questions about school. It asks about social environment. When they come home, do they go straight to their room and close the door? You know what I mean? And it talks about things, and it talks about risk factors. Because if you think someone you love is at risk, get an assessment. It can do no harm. It can do no harm. Get them assessed. And if they do it right, they'll take them to a place where the people know how to talk to people and get them to open up. I deal with kids all the time that are afraid to tell me anything because they think I'm going to talk to their PO. First thing I tell them is like, bro, I work for you, not your PO. I work for you. And that being said, that information is extremely valuable. And if you think somebody's at risk, find a place where they have that skill of meeting them exactly where they're at and getting them to open up about this. Because the problem really comes in with adolescents not talking about this. And trust me, we live in the age of fentanyl. They might not make it to adulthood. I hate to say that, I'm not trying to put that out there, but it is a reality. Matter of fact, we were talking about this in an all-staff meeting, is that the statistics for alcohol are way up in the youth facility. I have numerous kids that are primary alcohol users. We're like, well, that's weird. Because it used to be like marijuana, it used to be, methamphetamine, opioids. Why is it alcohol? Well, did a little bit of research. It's because they're terrified. They're absolutely terrified that anything they use could be laced. I mean, you can literally smoke a bowl and die. I don't know what I'm buying. Oh, look, there's a Percocet. Yeah. No, that was made by the cartel, Like, they just don't know. It's just dangerous out there right now. I'm not saying it wasn't when I was a kid, but very few things would kill me in the first hit. But now they're terrified. They're absolutely terrified. So the answer is a bottle of vodka. Great choice, bruh. Same damage, but it's just something that gets missed. And yes?
I was just going to say that's really interesting to hear.
Is it?
The CDC just released data last week that said overall the country is drinking less alcohol.
Yeah, that's good. Well, that probably didn't include adolescents.
Well, I'm not sure, but that's interesting, right? I also work in Lincoln County Jail. I really wish more people would be afraid of what's on the streets.
Oh, I agree.
Yeah.
Actually, I read that study. I do know that, and they did include that. But what we were talking about that, I forgot, is that they're selling less alcohol.
Oh, okay. So
But the kids steal it. Kids steal it.
Yeah.
I mean, there's, we put it in the aisles at Walmart. What the heck?
Yeah.
So I got to tell you this story, man. I don't know. Anyway, so I had this patient. I love this patient. He was here before. He's one of my favorite people in the world. And he came in, and I'm asking him. I'm doing the intake, and I'm like, and I'm a heavy metal fan, right? So I asked him, I'm like, hey man, so I heard you just stole some alcohol at Walmart. Tell me about what happened. He goes, well, Ozzy Osbourne died, bro. I'm like, oh, I love this kid. What an excuse to get drunk, man. So I called my best friend, and I'm like, who's one of the managers out there, he's like, you give that kid a gold star. So yeah, they're drinking more, so very good. All right, so here's the physical risk. So obviously, addiction alone, people are like, here's the interesting part. People ask me all the time, well, what's the safest drug? And I'm like, well, statistically speaking, it would be heroin. Right? I know, everybody's like, what are you talking about? Well, it does the least damage to the body. You know what I mean? The least damage to the body. But that doesn't mean it won't kill you. It just won't give you liver failure the way alcohol will. You see, the thing about addiction is it's suicide on the installment plan. A lot of these drugs will kill you slowly and over time. Let's talk about some of the risks. Okay, so neuroadaptation we talked about. This is a huge risk because it'll affect our mental health. It affects our ability to feel pleasure. And it actually presents with what we call dysphoria, severe depression. For me, when I wasn't high, I couldn't even get out of bed. I couldn't even hang out with myself. So I needed to stay high all the time. And in early recovery, I felt like I was mentally ill. I really felt like, I'll never be happy again. But I had to let that neuroadaptation heal. So that is one of the risks. And by the way, the reason I put this on here is because long-term use of methamphetamine can permanently damage the reward pathway. Some people will not come back. All right. Obviously, heart and cardiovascular problems. Now, that being said, alcohol is linked to high blood pressure, hypertension. It's linked to all kinds of cardiovascular problems. Methamphetamine, gee. So that being said, what happens when you use methamphetamine a lot? Your heart enlarges because you're not sleeping and it's pumping so fast. Your heart grows muscle and it enlarges and it gets heavy. So it can cause a lot of problems. Obviously, cocaine. Anybody remember Lynn Bias? The basketball? Yeah, and his heart exploded on the court because of cocaine. So like there's a plethora of heart problems that can occur. And obviously lungs and respiratory systems and respiratory infections, depression. That's how opioids kill, by the way. Opioids come in and they tell the central nervous system, hey bro, just take the day off. You don't need to breathe. Don't worry about it, man. Just go to sleep, you know? And so we have respiratory problems. Me, I smoked a lot of methamphetamine, and it obviously coated my lungs, caused a lot of problems. And by the way, we're talking, you know, when we want to talk about addiction, might as well talk about nicotine too, you know? Obviously, lung problems are going to be huge. That being said, and one that I forgot to put on here and I remember and I want to discuss, is with alcohol, esophageal problems, the esophagus. A lot of people, I just had a friend that was sober for a long time and he relapsed and he ended up in the hospital with a bleeding esophagus. You know, I mean, it's just horrible, like literally horrible. He had drank so much alcohol, it just melted, you know, the esophageal passage, and every time he'd cough, he'd bleed. And that can be fatal. Anyway, go ahead. Kidneys and renal system. Alcoholism causes a lot of kidney problems. That being said, a lot of drugs cause kidney problems. Intravenous drug use can cause kidney problems. Obviously, dental health. We call this mastication. So does anybody in here know why methamphetamine users have bad teeth? There's science behind it. It's called mastication. So what happens is when people are using drugs like that, they're not drinking liquids. And saliva kills bacteria in the mouth. If we don't have saliva, bacteria goes unchecked. These are all partial. So I learned that the hard way. This is State of Washington Department of Corrections paid for my teeth. Thank you very much. So, but now what I know is that, you know, I'm not being healthy because I have less things to fight bacteria in my life, and I'm inviting infections in. Go ahead, please. Overdose. What can I say? Now here's the thing though. When we talk about overdose, oftentimes people think about opioids. They always think about opioids, and that's the obvious answer. I can tell you right now that if my adolescent group was here, I would ask them, how many of you have overdosed on alcohol? And 5 out of 9 of them would raise their hands. 5 out of 9 of them have been hospitalized for alcohol poisoning, which, by the way, is an overdose. That being said, methamphetamine can cause overamps. We just talked about lead bias. So overdose can happen anywhere and anything. But obviously, we talk about opiates. Yeah.
I just want to add the role of those energy drinks
Yes.
that teenagers love that have high amounts of caffeine,
Yeah.
and so it's overriding what alcohol should do to their central nervous system to
Correct.
keep them from drinking, and
Correct.
so they are at higher risk
So
of
they drink
alcohol
more.
overdose because they're also drinking Red
Yeah.
Bulls and the other crap.
Well, and it's the same thing with people using Suboxone. They try to get high, and naloxone keeps them, but they use enough to shut down their central nervous system, and you can still overdose, even though the opioid doesn't take effect psychologically. So, go ahead, please. All right. Bloodborne pathogens. Obviously, bloodborne pathogens are a problem with dirty needles. Hepatitis C is a killer. It is a killer. HIV, AIDS, numerous things. Obviously, in treatment facilities, we use what's called universal precautions. We don't touch any bodily fluid. But obviously, there's tons of health risks that go with addiction. Please. All right.
Maybe popcorn.
I know, right? 6 years in the Army, buddy. I had a lot of ibuprofen.
800.
Right. Sorry. So let's talk about treatment for addiction, okay? So there are numerous different treatment options, and I'm going to talk about all of the treatment options. But one thing that I want to talk about is medicated assisted treatment. I'm hoping somebody presented really deeply on this. Is somebody presenting on that? Anyway, so I'll cover it as well as I can, but I'm not a doctor, but I do know a lot about it because a lot of my patients use it. The problem with medicated assisted treatment is there's a stigma with it. You ain't sober. I get it because I was one of those people 15 years ago. I was one of those people. But what I do realize now is that my job is to keep my patient alive long enough to want to get sober. And that being said, you know, a lot of people, they look at things like a safe injection site and they're like, oh my God, they're selling drugs to them people, they're letting them use drugs. Well, let me tell you what they don't know. When you investigate that, I'm not advocating for them, I'm just telling you why I'm open-minded to them. When a person goes to a safe injection site, I know I'm veering off into harm reduction now. When they go to a safe injection site, the first thing they do is they meet a social worker, and that social worker says, hey Dave, would you like to go to treatment today? You ready for services? I'll tell you what, if you go to treatment today, I got a $100 gift card at Target, we'll get you some new clothes, and we'll take you to treatment. Want to go? It's the first thing. The first thing. And that might be the only time that guy has been offered services in months. Now, if he says no, okay, no pressure. We're going to check your dope for fentanyl, make sure you don't die. And we're going to stand by with, Narcan in case you do overdose. And then he lives another day. And then he comes in tomorrow, and I ask him again, hey Dave, you ready to go to treatment today? You see, sooner or later, and so what we're doing is we're keeping them alive long enough to want to change, which was done for me. Well, that was done for me. In the year 2000, my life was saved by a SWAT team, but it was saved. They were my angels in black, So we're going to talk about Suboxone, methadone, naltrexone, but let me be absolutely clear about this. The problem when we first started using this was that any doctor could take an 8-hour class to prescribe Suboxone. And so Billy Bob comes in and says, I need some Suboxone. And the doc's like, okay, here you go, you're saved, you're cured. Thank you. No, he's not. He's only going to use that Suboxone when he don't have any heroin. Or when he doesn't have any Fetty or fentanyl. My peeps call it Fetty, so it's like Fetty, man. So the problem with that is I want to make absolutely clear, medicated assisted treatment works the best in conjunction with behavioral therapies and peer support. Meaning, learning how to deal with, the cognitive processing difficulties, cognitive behavioral therapy, dialectical behavioral therapy, acceptance and commitment therapy, and ways to deal with your feelings. Because if you don't learn to like yourself, you won't have the ability to stay sober. So just prescribing somebody a drug and telling them they're sober should be criminal. Okay, so I want to make that absolutely clear that I'm not saying this is all you need, but it is a very good tool because before we started using Suboxone, or before we started allowing it and having our doctor prescribe it at Sundown Ranch, we had this big meeting, like, why are we losing all the opioid people? Well, in 5 days after the withdrawal, they'd all get well. They'd be like, oh, hey, no withdrawals, Dave, I'm glad I'm cured, I'm out of here. And we call it getting well, and they just leave. And then people would leave because they're afraid of withdrawals. The problem is you have to keep them long enough to engage them. So it has literally changed the way that we do things. And I work with adolescents, so I would never advocate for an adolescent using Suboxone for the rest of their life. Ever. Now, that 63-year-old guy that just got out of prison for the 5th time, you know what I mean? And he can't stay sober, his quality of life may be much better with methadone. It might be much better with Suboxone for the rest of his life. But that's because the quality of life. I work with adolescents, so I never talk to them about long-term use. Go ahead, please. So, Suboxone. Oh, wait a minute. Whoa. Go back. I'm sorry. I thought I must be missing some slides. Okay. So let's talk about Suboxone. I thought I had some slides in there that talk about Suboxone. So Suboxone is a drug which is actually an opioid, but it has what's called a ceiling effect. They bundle it with both naltrexone and naloxone, and I'll talk about that in a minute. So naltrexone, it limits the effect of opioids. So naltrexone makes it to where you get high, but not like fully high, and so that meaning it has a ceiling effect. Like they can actually give very big doses, and the person just won't get any higher. But at first they kind of do get high. But they also bundle it with naloxone, which is what we call a full opiate antagonist. It will remove the opioid from the new receptor sites and block the effects. And they do this, like you take Suboxone sublingually, they put it under their tongue. But if they try to cook it up and shoot it, the naloxone will completely block any effect and they'll go into what's called precipitated withdrawal. So they get punished for doing that. This one bites back. So it's a really good thing for addicts, okay? Now, we talk about methadone. Methadone just kind of changes the way the brain perceives opioids. And the reason this is good for people, and I was talking about the person, if nothing else has worked, I mean, come on, man, the guy deserves a quality of life, you know? The problem with people with methadone is everybody's like, well, that's not sober. Well, maybe not, but it's a much better life than he had before. And now he can be a useful, productive member of society. And really, that's what harm reduction is about. It's about saving society, not the addict. But it does have its place. It does have its place. But methadone lasts for 24 hours. That's why it's so valuable. A person can come in and take that dose and be good for 24 hours. I mean, it's kind of, it works. I mean, we don't use it, but I'm not saying we shouldn't. Now, naltrexone, amazing. Absolutely amazing. So naltrexone is just saved a lot of lives. Because what naltrexone will do is it will block the effects of opioids. But it can also be used with alcoholism. Because what we have found is that naltrexone, and we don't know why, by the way, I kept looking for the science, and it's just, we don't know why, it's just reported, is it reduces the pleasure that you get from alcohol. So alcoholics relapse, and they're like, damn, this sucks. You know? So, okay. The good thing about naltrexone is it can be given in pill form, but they also have, and that's, I had all these slides with all this information on them, and I don't know why they're, and I must have not updated that. But naltrexone can be given in an injectable form and last for a month. And this is called Vivitrol. The problem with that is, well, I don't know if I should go there. No, insurance companies. The shot costs $1,400. Yeah, and it can save lives, and it's really important, so let's charge really high for it. And so a lot of insurance companies, when we want to get a patient a naltrexone shot, we have to jump through all kinds of hoops and utilization reviews to get the insurance company to, you know, I'm not going to start dissing on insurance companies because I would go on a rant. And I'm not really trying to do that. So, yes?
It is covered by Medicaid, though.
It is covered by Medicaid, yeah. NVA. Okay, yeah, I didn't know that. Yeah, I was aware of that. Anyway, I had some bad experiences. Like, okay, well, I guess you could pay for their funeral. You know, I get really frustrated. But naltrexone is amazing. You know, obviously, if Dr. Raymond prescribes it, he'll do it in pill form for a few days to make sure they don't have an allergic reaction. And then we always recommend the Vivitrol because it takes the addict out of the equation. You know, because if I'm taking a pill, I'm just like, oh, guess what? I just got some fentanyl, so I don't think I'm going to take my naltrexone today. You know what I mean? Like, we can plan our relapses. When you do the shot, you don't have that choice. So it takes the addict mind out of the equation. Okay, go ahead. Let's talk about treatment options. So we have outpatient treatment, which we call level 2.1. Don't ask me why. Level 1 is regular outpatient. Level 2.1 is intensive outpatient. So outpatient can have varying lengths. So outpatient treatment is usually you live at home, right? And you either report on Zoom or you come to the meetings, and there's education, there's group process, maybe 3-4 times a week for about 4 weeks, and then you go to a lower level of care and everything like that. And it's a combination of psychoeducation and group sessions. And they do use behavioral things. Now, a lot of Suboxone programs are outpatient programs, and they have to come to group to get their Suboxone. It's brilliant. It's absolutely brilliant. You know what I mean? You have to, we call that contingency management. There's some kind of a, you know, they get rewards, like if you come to 4 groups in a row, you get a $50 gift card or something like that. You know, it's a really good way. The carrot has proven way more powerful than the stick in addiction treatment. All right, so outpatient treatment is just that. Go ahead, please. Inpatient treatment, usually 28 days. The youth program I work for is 45 days because we want to get them halfway to their readaptation mark. Not only that, we realized a long time ago when we were 28 days that most of the patients we met were in a stage of change we call pre-contemplation, meaning that they're not really thinking about change. Mom and dad searched their room, found some stuff, and brought them to treatment. So it's not their idea to come to treatment. So we wanted some time, some extra time to move them into a stage of change that would make them more amenable to treatment. So that's why we are 45 days. But adult programs are normally 28 days, 4 weeks in treatment. So they're covered by medical insurance, including the VA. Many, I know our program and a lot of programs will accept inpatient treatments. Now, does the VA contract with certain inpatient programs, or do they just work with any?
Well, I know Seattle VA has, the VA has an outpatient, but I'm not sure about.
Right, right, yeah.
Maybe honest, people that have-
Does anybody know? Go ahead.
The VA pairs with Royal Life.
Oh, good.
And they have a bunch of treatment centers through like Florida.
Perfect,
And Arizona
perfect.
and in
Yeah.
Washington.
Now, I do know that we at Sundown have had treatment paid for by the VA before. I think that was a special contract or a subcontract. But a lot of facilities, we also scholarship, by the way. Like if a person can't get it paid for, we'll be like, oh, come on in. You know what I mean? Like I know we do that. We do that a lot. So don't wait a minute. Okay, if Scott Munson calls, you didn't hear it from me, okay? I can't believe I just said that. Oh no, back one, please. Yeah, please. Okay. So the thing about inpatient treatment is a combination of psychoeducation and intense group and individual sessions. And it's much, oh, I keep walking away from the mic. I'm sorry, I usually walk when I present. So, the reason inpatient is more intense is because they live with us. Now, if I'm in an outpatient working with an adolescent, I'm not going to take him through the trauma. Because, man, I got an hour and a half with this young man, and I don't want to open up a whole bunch of wounds and send him back out on the street. An inpatient is a totally different story. We can go there, we can do that, and it's much more intense. And then we have staff 24 hours a day, so we just put them on a 30-minute watch. They observe and report their behaviors, and we see how they're processing that trauma. It makes it, for me, I love working inpatient because I get to work with a patient, write a treatment plan, and follow that treatment plan all the way through. So, for me, inpatient is just way more intense, absolutely more intense. And that being said, the person will leave there with at least 30 days sober, which gives them a huge advantage. So it's much more intense than outpatient. Go ahead, please. So, obviously here the veteran resources on addiction treatment right here. I did look at this. It was kind of, didn't name any real treatment facilities, but it talks about how to access the services for addiction treatment. So, I know that the VA thinks, go ahead.
I just want to put a plug in for the PPW.
Oh, yeah?
Because we have women veterans, and if in the state of Washington we have 180 beds statewide for women to go into treatment with their children if they have addiction issues.
Right.
Each treatment center has a different age level.
Yes.
But like Yakima, here we have Triumph Treatment Services.
Yes.
3 of those facilities.
Yeah.
And so if a woman's using during pregnancy, they can go into a 6-month residential program.
Absolutely.
With their children, and they also are eligible for the Parent-Child Assistance Program, which will provide 3 years of case management.
Absolutely. Now, and I just want to make clear that that is a very good point, and when we assess for appropriate needs. Like if a person presents to Sundown and they're in that situation, we will refer to Triumph because it may fit them better. Ethically, we're a
Women need to
nonprofit.
be
It's
in
not
the
about the
treatment.
money. It's about the ethics. What? Even though we're not free, don't tell Scott I said that.
From what I understand,
Yeah.
the VA, Walla Walla, VA Boise, Medical, or American Lake, Medford,
Yes.
Oregon, they all have their own facilities, so they're
Right.
gonna try to get you to go to their facility
Facility.
first, depending on where you're at.
Yeah.
And then if you can't get you a bed day within 30 days, they may either send you to another facility outside your general area.
Yeah.
Like for here, it's Walla Walla, right?
Yes.
So if not, then the next step is to community care. So you can't just go to the VA and say, hey, I wanna go to.
Right,
XYZ.
right, okay.
They're gonna try to have you go to the VA facility,
Okay.
and then a couple steps after that.
All right, well, once again, there's a link that can help you access those services. But yeah, that sounds about right. All right, so one more slide, please. So, yeah, the first 58 years of my childhood were a little rough. Just saying. All right, go ahead. So, now we talk about peer support groups. So here's the thing. You go to treatment and that's great, we dry you out and everything, and we teach you these skills, but we also talk about community because I can promise you recovery is about connections. I promise you that. Connections with a therapist that you trust, connection with people that you feel comfortable with. And many of us have used the 12 steps of either Narcotics Anonymous or Alcoholics Anonymous. Now, is this the only way to get sober? No, it's not. But it is a statistically proven way to get sober. And some of the programs out there that we refer to are Alcoholics Anonymous, which were started by Bill and Bob back in the 30s. And they just kind of discovered, they fell into this because the therapeutic value of one alcoholic helping another is just beyond parallel. Okay? Narcotics Anonymous, that's where I got sober. Narcotics Anonymous. Cocaine Anonymous, they have to be special. Marijuana Anonymous, they have munchies at their meeting. Dual diagnosis, by the way, this is actually, I've been studying this program, and for people that have dual diagnosis, it's really well, because you can go there and talk to people. You can talk either about your addiction or your mental health struggles, because a lot of people with addiction struggle with maintaining consistent medication. They struggle with consistent feelings of up and down and whatnot, and so you meet people that have a similar thing. So I really am really excited about this. I think it was much needed, because oftentimes back in the day, you'd go to a meeting and you talk about mental health, and they're like, you're just an alcoholic, or, you know what I mean? Like, they don't want to hear it, you know, it didn't work. But not all meetings are like that, by the way. That's just kind of like, some people, there's still a stigma attached with mental health, even for alcoholics. Can you believe it? Alcoholics judging people for mental health. I don't know, who knew, you know, but that being said, I'm really glad. Now, Celebrate Recovery. Has anybody heard that? Yeah, it's a spiritual, faith-based. It's from churches, and it includes more of biblical stuff in the 12 steps. So for people that have a religious connection with the church, it's absolutely fabulous. And by the way, I really like the way the churches support these. They really do, and they've kind of integrated, you know, your spiritual life into your recovery. Celebrate Recovery. I talk about this all the time, because like when I'm working with that adolescent, I want to find out if they're involved in any youth groups or Young Life or anything like that, because obviously connections, I'm looking for connections. Gamblers Anonymous, because in Sundown and Ranch, we have a section that talks about gambling. And we will put that in a treatment plan, because once again, we talked about dopamine, we talked about neuroadaptation. You know, that being said, gambling is the same thing. We get that hit of dopamine every time we get a hand at poker or whatever it is that you're doing, you know, we get that hit of dopamine. So Gamblers Anonymous is another 12-step program that tends to work. Go ahead, please. All right, so Smart Recovery is another treatment option. I use a lot of their stuff. I absolutely use a lot of Smart Recovery stuff. You know, they're nice open source, so I can download it and not worry about copyright. They're dedicated meetings for veterans and first responders. They have a family component, but that meaning they have dedicated meetings. They have special population groups. Like if you're a police officer and you need to go to treatment, you know what I mean? There's a stigma attached with that. And that's why we have confidentiality laws, by the way. But that being said, a police officer sometimes may not want to sit in a group with a bunch of people that aren't like-minded. So Smart Recovery offers special population groups of first responders and veterans, because there are special needs there. There's special trauma. There's special resources. An individualized treatment plan for that individual. So I incredibly respect Smart Recovery. I really do. And you can find them at smartrecovery.org. Next, please. I don't know, I might be about done here. Keep going. All right, this is the questions part. All right, we've got what, 25 minutes? Okay, I need your questions. Yes?
I work with the VA in Spokane. Where can you access information about facilities for sex addiction, porn addiction, things like that? Because it's always a question.
Sure. So I don't know the exact answer to that, but I do know that like if a person presents for us for a substance use disorder assessment, we find that to be, we will direct them where they need to go. But I don't know the specific answer for where they can access those. I'm really sorry about that. I only work with addiction. That's kind of out of my scope of practice. But I'm sure it's out there, because consistently, that is, and once again, it's all related to dopamine. Porn addiction is related to dopamine. Any kind of addiction that we've found have done that. Okay? Yes?
There is a 12-step group.
Here, let me have this to you, sir.
Sorry.
There is a 12-step group called Sexaholics
Yes.
Anonymous.
Yeah. No, that is true. There are 12-step groups. Oftentimes, though, the treatment is also involved with that. But I do know that there is a 12-step group for almost everything now, which I think is fantastic. Because Alcoholics Anonymous and Narcotics Anonymous have made the steps open source. They can apply to almost anything. And I think that's awesome. Yes?
Mine's more of a statement.
Yes.
When we first moved to Washington, and my wife was working at Western Washington University in the counseling center,
Yeah.
they briefed her and they told her that she would have to ask about marijuana separately because the students just don't even consider it a drug.
Yeah. So I do a marijuana lecture, by the way, because I work with adolescents, and I just need to let you all know that every teenage stoner has a PhD in weed that they got from 420.com, okay? So I learned that it cures cancer. I mean, I'm like, wow, bruh. So I've learned a lot of facts because obviously if I'm talking to an adolescent, I want to provide facts. I just ask them, like, where did you learn that? You know what I mean? Like, have you ever heard of a citable resource? You know. So, but the thing is that is more than common now because with the legalization of marijuana, a lot you can't ask about it on applications. Now, I would hope that that's not true with airlines or doctors. I mean, I don't know. I mean, I just hope my doctor doesn't take a dab before he does surgery, you know. So, but it's more of a common thing. You can't even talk about it anymore. The problem is, and by the way, I'm about ready to rant here. I'm not anti-marijuana, but I am anti-adolescent brain using marijuana. Because while the adolescent brain is forming, remember the pathways, the neural pathways that we're forming get used. The ones we don't get pruned. And so when a 13-year-old doesn't learn how to deal with social rejection and just smokes it away, he's going to grow up to be a 38-year-old man-child like I was when I entered treatment. You know? I never paid a bill. I didn't know how to be an adult and that started because I started smoking pot at 13 years old. So yes, I'm anti-adolescent using marijuana.
I was just going to say there's just also a really scary research about the correlation, not necessarily causation, between adolescent marijuana use and the onset of psychosis, which can be schizophrenia.
Yes, I have that slide in my lecture. And a matter of fact, 3 times more likely to develop schizophrenia. 5 times more likely if it is in your family. Now the reason that we're saying this is it's not your grandma's weed anymore. So the last time I smoked marijuana, it was 12%. It's now 99% in some of those vape cartridges. So the levels are just crazy, and so you're significantly more likely to get a psychotic reaction. By the way, the #1 call to the Poison Control Center in 2025 was because of edibles and dabbing. People wanting to know how to not get high. 539,000 people between 2019 and 2023 went to the emergency room in America for cannabis-related problems. But it's only weed.
Plus we're seeing it in children.
All right, I'm ranting now. I'm backing up. Deep breath. More questions? Yes.
So, should be good. So, knowing that with veteran population, it's a very diverse population.
Correct.
Is there a correlation between, say, ethnicity and predisposition for addiction that we might want to address when we're talking with different ethnicities? I work specifically for a tribal entity.
Okay. So I'm glad that you said that because I didn't want to sound insensitive to that. But Dr. James Milam, who from the Milam, well, now it's called Lakeside, but Dr. James Milam wrote a book called Under the Influence, and in there he addressed that. And he remember we're talking about genetic predisposition. So for me, I come from a European background that is like, hundreds of thousands of generations. So we've been exposed to alcohol for thousands of years. The Native American population, we're talking 300 years. You know what I'm saying? So of course there's a huge susceptibility to that, to where many tribes are full-blown alcoholism. So there is a huge risk factor with that. And it is, like I say, Dr. Milam has a really good book where he talks about it called Under the Influence. So yes, absolutely. And by the way, Eastern European populations, Russian, you know, there's a lot of races have genetic predisposition that we just can't explain. Some of that could be cultural though. Like when you grow up in a culture where, you know, like, well, when you talk about the Native American, they would never abuse peyote. You get what I'm saying? Because it's a religious, you know, but so it's not ingrained in their culture at all. So, yes.
I've got two things. One, that book is actually really good because that's some of the, for what I do, that's what a lot of the soldiers, that's the clinic that they go to.
Oh, yeah, Lakeside?
Yeah.
Yeah.
So
And they get issued that book.
they do.
Yes.
So
Awesome.
I've actually, when I toured the facility,
Yeah.
I was able to get a copy. It is really good.
Isn't it? And it's old, but it's still solid as a rock
It
today.
is.
Yeah.
I was surprised how
Yeah.
old it was, how
Yeah.
it's still
Yeah.
applicable to today. And for facilities, if you ever want to find something similar, I don't know if they had the exception one, but a
Yeah.
lot of other ones you can narrow down, like if you need a certain insurance, whatever.
Yes.
Is, so I use findtreatment.org.
Ah,
And you can
findtreatment.org.
actually put like your zip code or county, whatever
Yeah.
it may be, and it will find, and there's
Yeah.
a lot of different boxes you can check for if you're looking for mental, substance abuse,
Perfect.
a lot of different ones, what type of insurance you have.
Yeah.
whatever it may be.
Which is important.
It'll show,
Yeah.
it'll populate that.
And see, I think that's great because like that's the problem is like you find a treatment center you want to go to and they're not contracted, you know, they're not CARF certified, you know, so your insurance won't pay for that.
No.
Yeah.
What was the name of the book again?
Under the Influence by Dr. James Milan. And it's a great biology of addiction type stuff. I read everything in the biology of addiction. So, right, okay, so we had one over here too. Yes, go ahead.
Sorry.
No, you're fine.
I really like the definition of trauma that you gave for your definition of trauma, but I didn't get it all written down. Would you mind
Okay.
saying that again?
So trauma doesn't mean just abuse. Trauma can be anything that psychologically scars you. Being abandoned as a child, oftentimes I work with, as a matter of fact, probably 4 out of my patients right now have an attachment disorder because their parents were never there. So that significant trauma has formulated how they act in the world, and they will never have a healthy relationship until they figure that out. And 2 of them are on a no co-ed contract for, you know, because they're seeking their future ex-wife in treatment. So. Well, we have a sign when you drive into Sundown Ranch. It says, "This is the first day of the rest of your life." So I tell them, "Bro, first day of the rest of your life, not the first day of your future ex-wife. Get it right." But yes, yeah. So trauma is like anything. And that's the problem, is everybody's like, well, you don't have trauma. Mine was shame. Whatever psychologically scars you is trauma, and we need to be aware of that and sensitive to that. Yes?
My concern is Suboxone.
Yeah.
So I work street outreach.
Oh, yeah.
And I see fentanyl as an epidemic in
Yeah.
our
Oh,
streets.
yeah.
And Suboxone blocks your opiate
Yes.
receptors. And so what I wonder is, are we paying more attention when we're giving people Suboxone? Because it creates more of a chance of an overdose.
I agree. Yeah. Now, you guys understand why that is? And what she's saying is Suboxone creates a bigger chance of overdose. The reason that is because it's bundled with what we call naloxone, Narcan. So like, it's got naltrexone, so I feel a little bit of the opiate, but I don't feel the way I want. So we continue to use the opioid. And although we don't get the euphoric effect, we still have enough to shut down our central nervous system. So yes, you're absolutely correct. And that's why I say that Suboxone should never be used outside of a treatment environment. That's my opinion. And that's what's hard, is we're just like, you know, hey, let's give them some Suboxone and they'll be fine. Well, you know, they're not. Because the bottom line is what many people are doing is using the Suboxone when they don't have drugs. And to keep them from going into withdrawal. And then, the minute they have drugs, they stop using the Suboxone. And then, you know, so it can be a total problem. Is it a miracle? No. It's a great tool. It's a great treatment tool, but it is definitely not an answer.
I think that it's long term.
Yeah.
You just say I'm going to teach you how to use Suboxone
Correct.
and give you the shot.
Yeah.
I feel like,
Yeah.
but you have to be on a treatment.
Well, and I think it's absolutely wonderful to start a program and let them know that there will come a time when we're gonna titrate you off this. You know what I'm saying? Like getting them prepared for that, if you can. There was a question over here.
Right here.
Right? Oh, yes.
Thank you so much, this is fantastic.
Oh,
I'm the
great.
first case manager at the VA, and.
Oh, yes.
And I get approached all the time by family members, I'm so concerned, they're using, I need help. Do you have any recommendations?
Yes.
For, because this is, yep.
Yes.
I see this, I'm tracking all this, how to bridge from everybody else sees all of this and knows we need to get help, how do we bridge, sort of making connection, yep, how do we help them see this stuff to get, and I have a tough population.
Yes.
When you're talking about the culture.
Yeah.
Pilots in the military, they
Yeah.
have a bar in their break room.
Yeah,
So when they get out and they can't go sleep without whiskey, and I'm like, hey bud, maybe we might have a problem
Yeah.
here.
Yeah.
There's lots of barriers to that, right? They
There's
run into
huge
problems with
barriers.
the FAA, they run into problems. So how do I get from, I know there's a problem, everybody else knows that there's a problem, how do I get you to help?
Well, I guess the first thing is learning how to approach that. And the problem with the population you're talking to is it's dangerous for them to talk about it. And it's the same thing like with a first responder, you know, like a police officer or a doctor. It's very hard. And there are many, many programs, us included, that have what we call impaired professional groups. And so I would call a treatment center. I mean, I know you could call us and we could talk to you about that, but like there's always a way to try to approach that. The problem is that unless a person has the negative consequences, they're not going to be willing to do that. Now, research shows that the best money spent is prevention. The only problem with that is that you usually don't know there's a problem until the symptoms start to present. So that is a really hard one, but there are impaired professional groups that can do that, and there are places that can direct you in that area. So.
Because unfortunately, it's not until their wife leaves that
Yeah.
they're like, whoa.
Yeah,
there's
yeah,
a
yeah,
problem.
yeah. Until there's consequences, they're not, it's gonna be hard. Yeah.
Well, there's also motivational interviewing. So
Correct,
if you're not
absolutely.
trained in motivational
Yeah.
interviewing yet, you should
Yeah.
get to train so that it's like a second breath to you to be able to work with these folks.
I would
Because
agree.
that is about moving them from
Correct.
pre-contemplation
To
to contemplation to change, et cetera, et
So,
cetera.
so what she's talking about is motivational interviewing by Miller and Rolnick. There's a great book called Motivational Interviewing, Preparing People for Change. I actually do presentations on that as well. I train on motivational interviews. And what it is a very non-judgmental, happy, fluffy way of asking questions, open-ended questions, and eliciting information and making them feel comfortable. And for anybody that's got to address this with anybody, working with adolescents, it's mandatory, because the best thing is when you get good at it, then all of a sudden they want to change and they think it's their idea. When you've just been kind of like leading them with these questions and we build a script and say, wait a minute, like, okay, now I know that you said your goal is to have a better relationship with your mom. How? And I get it, you still want to smoke pot. I'm totally cool with that, but how's that gonna work? And then they have to start explaining that, and they're like, well, I'll only smoke on Wednesdays, and then the group's like, oh yeah, bro, so it works beautifully. Did you have something?
Yes, sir. On the topic of medicated assisted therapy,
Yeah.
So let me get some information background here real quick. On August 11th, the Drug Enforcement Agency filed a formal petition to the Health and Human Services Department to reclassify psilocybin from Schedule 1 to Schedule 2.
Correct.
And then currently here at University of Washington, there's an active study for veterans with PTSD and co-occurring alcohol use disorder.
Yes.
They're actively recruiting veterans into that right now. And then in Texas, they are spearheading an effort using Ibogaine for opiate addiction.
Yeah.
So when and I'm kind of open this question to any of the experts in the room here, but whenever I've spoken to addiction therapists, the idea of introducing another substance to overcome a substance predominantly is not supported.
I would disagree. I would disagree with that.
In listening to your therapy, or listening to your presentation, I see that same thing too. So I'm just thinking, what is the future state of addiction treatment if these things are becoming available? And I mean, if psilocybin moves to Schedule 2, that's gonna be a very quick switch.
Well, it may, but there's a reason that they're doing that, because they want to microdose. Now, my answer to that would be that anybody in the helping profession that is a therapist or has dedicated life should be open-minded to anything that can help their patients, whether they understand it or not. You get what I'm saying? Like, if I say, well, that's wrong, that's wrong, that's wrong, who the hell am I to say that? You know what I mean? I need to be willing to adjust. I need to be willing to say, hey, maybe it works. Let's let the doctors do their research. Now, psilocybin and methyl-deoxymethamphetamine, MDMA, microdosing has been showing some incredible results with mental health and attachment disorders. So, but the key is they're not introducing a substance, they're microdosing it. The problem comes in is when you have these stars getting ketamines, you know, getting ketamine off the street. Now, ketamine is an incredible medication when used right. The problem is not introducing the drug, it's how the addict is using them and how it's supervised. But yes, I think that anything that may have medical potential, we should explore. Things are changing, and they're changing quick. We didn't know about motivational interviewing until 2003. You know what I mean? Like, everything changes all the time, and then we find something that works even better. Suboxone has not really been around that. I mean, it hasn't been used that long. So I would disagree with anybody that says that. That's just me. That we should be open-minded to anything that can help our patients. That's why I'm open-minded to harm reduction. Does it fit into my world? Well, no. Well, does that mean I should oppose it? So, sorry, I'm starting to rant again. Deep breath. Acceptance and commitment therapy. Put it on a leaf. Okay, move on. Actually, my kids say, put that on a leaf. Anything?
Is EMDR effective for addiction?
Yes, actually it is, and because it treats trauma. And trauma is associated with addiction. And when we talk about treatment, we talk about a mixture of behavioral therapies and psychoeducation. So we're teaching about addiction. I do the biology of addiction lecture. I do a marijuana lecture. We're teaching the addicts about the pharmacology, but we're also addressing the feelings, the trauma. You know, we have to do that. So EMDR, sometimes with significant trauma, if you can deal with that trauma, you have a much better chance. So yes, I think it fits great with substance use treatment because it addresses a lot of the issues. You know, yes?
The American Lake VA has an inpatient unit for substance use, and they, right next to it, they have an inpatient unit for PTSD.
Yeah.
So they treat the substance and the driver, so they come out after 3 months or so with tools for both.
For both, exactly. Because if you know, you treat, like, if you don't do like dual diagnosis, you treat the addiction, and now you have a severely depressed alcoholic. You know what I mean? Like, a lot of treatment should include those skills, the behavioral skills. We use acceptance commitment therapy. We use dialectical behavioral therapy. Don't tell Marsha Linehan, I don't know if you've licensed.
No, she's okay with it.
Okay, cool, okay.
She's cool.
Okay, I just gotta be careful saying DBT. But the thing is we employ a lot of different modalities because of the fact that we need to treat the holistic thing. Like, yes, this person is using a lot of opioids, but they're also very volcanic. They're constantly becoming angry because of real or perceived threats to their self-esteem. So if I don't teach them emotional regulation skills, they're not going to get sober. So we do have to treat the whole thing. So I really like hearing that.
So just one slight correction of that. They're not inpatient programs, they're residential programs.
Oh yeah.
So slightly different modalities.
They are, sorry. Residential, level 3.5.
So one question, we talked about naloxone.
Yeah.
Can you speak more to that as sort of the emergency rescue?
Yes.
In terms of respiratory depression?
Absolutely. So naloxone is Narcan, by the way. You've all seen it, the nasally, well, a lot of it's nasal, some of it, you know, you can introduce it. Like, every patient that comes in, we give Narcan. Now, we pass it out. I've got like 15 boxes in my office. I give it out like candy. You know what I mean? And what this is an emergency use. If a person is overdosing, the opioid has bonded to the mu receptor sites. And what Narcan is and naloxone is what's called a full antagonist. It will go in there, it will take the opioid off the mu receptor site, throw it out, and then block the effects. Now, the person will wake up, and they'll usually wake up really angry, because that's what's called precipitated withdrawal. Matter of fact, before we give Suboxone, we have to put them on what's called a COWS. I always tell the patients, man, you're not gonna like this, but I gotta wait until you're hurting to give you the Suboxone, because what it will do is it will unseat the opioid and put them in even worse withdrawal. So Narcan is used as an emergency, because that being said, the opioid is gonna suppress your central nervous system and keep you from breathing. And hopefully, if we unseat that opioid in time, we may be able to stay comfortable. So, is that what we were asking? Awesome. And yes, thank you for that, because inpatient residential, like if I'm typing out a UR for an insurance company, I have to use the word residential. So, I get you.
Sorry. On that same line of thinking, we recently had somebody come to our agency and do the naloxone and
Yes.
all that training and everything, and talking about having to stick around to do a second dose, because they can actually
Yes.
overdose a
Yes.
second time once the first one wears off.
So the policy is like in our facility, what we will do is we'll give a dose, and then we'll take the thing and we'll put it in a pocket or something like that. So when we'll be able to tell the first responders how many doses that we've given them. You know what I mean? Because you want to, and oftentimes it takes more than one, depending on the person's tolerance. So it's not a miracle drug. People do still die after being Narcan. But that being said, it is fantastic that we can reverse that, because back in the day they couldn't. They just had to sit and watch people die, and it was horrible. Yes.
Is there a limited amount you should give a patient of Narcan?
Well, I haven't heard that there is, but I've never heard of it taking more than 2 or 3 doses. Have you?
In county jail,
Yeah.
5.
5?
5 to bring a guy to get him to breathe again.
Wow. Yeah. So, but I don't think it's going to kill them. I mean, there's no, I mean, obviously we don't want to give as many, but I would definitely tell the first responders that you gave them 5. You know what I mean?
And they need to go, because the opiates are still in
Yeah.
their system. All it's done is kick it off the receptors.
Right.
So as soon as it clears from those receptors, it comes back again. So they've got to go to the
Yeah.
hospital.
Well, I think it's also important to put out there that, naltrexone, like, even though it's really good and it's a partial agonist and it kind of blocks the effects, the problem is that people are taking the naltrexone and then they break their leg. There's limited pain options.
Yeah.
So all of this stuff has to be taken into account. So, I don't know, anything else?
And we have 3 more minutes, so we
Okay.
have time for maybe one more question.
Ooh, God, you guys have been fantastic. I really appreciate this.
So if you're not a medical professional or a therapist or whatever, and you deal one-on-one with clients that have substance use disorder and trauma and, PTSD and all that, is there some sort of screening tool or somebody you can send them to to decide what type of treatment would be most effective for them, depending on their genetics and their predispositions?
Absolutely.
And so forth?
So we have what we call the biopsychosocial. And what this is a huge assessment. I did one this morning before I came. And it takes about an hour. It's a bunch of questions, and we ask them about their addiction, we ask them about withdrawal, and there is a section in there on emotional and mental health. And we talk about, and a lot of these, we also we do what's called a PHQ and a GAD, which are for depression and general anxiety screens. We use these instruments. Now, if this person indicates high on the GAD, we have a mental health person, Becky, and what I'll do is I'll type in our little team chat, hey, blah, 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 and I'll type what the scores are, the record number, name, age, and she also wants to know how much, how much THC he's been hitting in a day. You know what I mean? Because all of this fits together. So we have a mental health person on staff, but our assessment is designed to examine these. Now, oftentimes, as a matter of fact, we do this quite often, if a person has significant mental health that is inhibiting their ability to get treatment, we will refer them to a more dual diagnosis type facility. Actually, we got a new one opening in Brush Prairie called Madrona. We're really excited. It's a mental health dual diagnosis place that we hope to kind of partner with and be able to refer patients to. So, yes, our assessments are designed to do that. And by the way, I have a doctor on staff as well. So when I first learned this, I learned staff. I never make a decision by myself. I always staff my patients, we have a team, everything is decided by a team, so yes, we do that.
And I'd just like to add, in Yakima County, Comprehensive Healthcare Services provides one-day assessments. You can send them.
Yeah.
Triage them and
Do they do
send it
that
to
in
your.
local too?
I don't know.
We have a comprehensive.
Yeah, they probably
I
would.
will check, but, I know here in Yakima, we got that grant, and so, anybody needs it right away, you just, they'll do it right in there, and they'll triage us, and whatever their needs, the highest needs are, they'll prioritize that first, whatever that might be.
Yeah, I used to live in Walla Walla for a few years, really high walls, though, I've never seen the town.
Really high what?
The prison. Just saying, really high wall.
I thought you meant around.
Great, big red wall. Yes. Oh yeah, overdose, International Overdose Awareness Day.
Next week.
Next week?
Here in Yakima, it will be on August 28th.
Perfect.
So if you're interested in it, please come.
Now, any questions? I love talking about this stuff. That is my email and that is my phone number. I have cards. I really enjoy being able to direct people in the right direction and talk about addiction. So please feel free to contact me for anything.
Well done.
All right.